Let's get started. Danny Kelly was going to introduce this, but he's just busy in another room. So he's asked me just to do this welcome. And he tells me that this is his note, the fellows, of which most of us are fellows of the Royal College of Nursing, are the unsung heroes of nursing. And I would certainly agree with that. This is the fifth in a series of events which have been on different topics, and they have been very successful, which is why they are continuing. So that's the end of Danny. I'm now switching to me. I'm Alan Kraft. I'm an FRCN and very proud of it. I've always been extremely supportive of nursing, even before I married a nurse. But nurses and doctors working together are hugely important. Just very briefly about me. I was a pediatrician. I started in the Middle Ages in 1969. I'm really a dinosaur. I started on a children's ward as a houseman, where there was still an iron lung, which had been used for polio, hadn't been used for a while. It was 2 wards for the whole of, well, it was for half of Newcastle, and we had 8 pediatricians in the whole of Newcastle. There are now 84 pediatricians doing the work that 8 of us used to do. All of the children have been amalgamated into one Great North Children's Hospital, where everything is in one place. Things have changed dramatically over the years. I particularly took an interest in pediatric oncology, that is children with cancer, at a time when there was not a lot that we could do for children with cancer. And in fact, 80% of children with cancer in 1969 died of their disease. And just as an example of how things have changed, if you take acute leukemia, the survival rates have gone up from about 10% in 1969 to 95% now. So an incredible change, and for other forms of cancer, things are better too. It's interesting if the question, what has changed? Well, clearly there's a lot of research which has gone on, which has improved treatments, but surprisingly, those treatments have brought with them, additional problems that we never really thought about. One thing which has changed is the parents' expectations of what we can do for their children. And now that we can do a lot for children with cancer, say, it's actually produced a whole lot of new problems. It was much easier in 1969 where there was certainty. If you introduce uncertainty, it's much more difficult for parents to cope with. One of the things we had to do to start with was to learn how to manage death, and got a huge amount of experience of children dying. And one of the things that I was very involved with nursing was developing the role of what became known as the pediatric oncology outreach nurses. They've had several names that, when I last knew them, they were POONs, but they arose, they were first called Rupert nurses. And they're called Rupert because there's a boy called Rupert who had cancer, was treated at Great Ormond Street in Bristol, and had a really difficult time in his palliative phase of life. And his rather wealthy father decided he had to do something about that. So he gave us a substantial amount of money to establish what he insisted that we called Rupert nurses. So Rupert nurses were children's nurses who took a special interest in cancer and in palliative care. and they have become a huge part of the care of children. They've kind of expanded their role now out of palliative care into, and Jane will talk more about this, into the care of children with complex needs. Because what children with complex needs and palliative care is just one bit of caring for children that have life-limiting, life-threatening diseases. So things have changed dramatically in what we can do for children. When I was just thinking on the way down, what is it, what examples are there of what has changed? Well, it is around parents' expectations. And we could talk a lot about that and how parents get unrealistic expectations. But we went through various phases. First of all, you were not allowed to die until you'd had steroids. And then you couldn't die until you'd had a trip to Disneyland. Now everybody wants to find every treatment that they can, so you're not allowed to die until you've had a crowd-funded trip to get the latest snake oil treatment, usually from the United States. And, and that has actually caused far greater problems than you can imagine. Parent dissatisfaction, parent unhappiness, about whether their child should go on being treated or not. I know that there's been a television program in this last couple of weeks about the difficulties. So these are all problems that we never envisaged when I started in this particular line. It's partly because we're living in a different age. We're living in an age of rapid communication, more information, news getting around. People are different. Parents are different. Children are different. And just to say one thing about the internet, one of the problems with the internet is that for the majority of people, and it's been stated that what the internet does is it gives you information without perspective. And really, it's just a higher form of ignorance. Internet's fine as long as you've got somebody to interpret it for you. But certainly some of the things of wanting treatment overseas, all of that comes from the internet. But we're in an internet world, and I think Ray may touch on this in what he's going to say. So what we're going to do is we have two guest FRCNs, and they are going to talk about, first of all, about themselves and what they've done. Then I have a series of questions which I'm going to put to them. And then eventually we will, not long, we will come to you, the audience, wherever you might be in the room or somewhere else. And we will allow you to put your questions to us. And I can tell you that Kath McCourt and Danny have just joined us. Thank you for coming. Is this just to pay me back for coming late to the FRCN presentation? Okay, so I've just introduced things. I've told people who I am, and we're going to move on to, it says Jane first.
Okay.
Are you happy?
Yeah, I'm very.
So Jane,
okay.
I want you to tell me a little bit about you and what your thoughts are on what has changed. Is it for the better? Is it for the worse? And what are our challenges?
Okay.
So over to you.
So I'll do me first. Thank you everybody for being online and also in the room tonight, and to you, Alan, for that introduction. I'm Jane Coad, and I'm a Professor of Children and Family Nursing at the University of Nottingham, where I lead a research centre for children and young people's health research called CYPHR. And I'm very proud to do that with my colleagues, Professor Sarah Redsell and Dr. Joseph Manning. And I have an amazing job in that I lead research around children and young people and babies with complex needs, very complex needs, life-limiting conditions, and if they go into palliative care, as we've just discussed. But I also have a dual role in that I am seconded to the University Hospital Coventry in Warwickshire, where I am part of the leadership team, being instrumental, I hope, to nurses, midwives, and allied health professionals' research careers. So that's something that is called clinical academic research, and I am very privileged to be seconded to do that work in Coventry. And I'm also able to do that work in Nottingham University Hospital. And as well as that, on Fridays, I am part of the community nursing team. I work as a volunteer in that team for South Warwickshire Foundation Trust. So I have all those aspects to my role in that I lead research for children and young people's nursing. I lead research in a trust, right, you know, the acute trust world, which is very interesting and challenging at the same time. And I also actually see things at the ground level, if you like, for children and families that I work with and the teams in the community care. So that is me.
Okay.
Shall we?
And in your spare time, you have 2 grandchildren.
I do, yes.
That she's compulsorily taking to the Tate Modern tomorrow at the age of
no option. I didn't say, before I was a nurse, I actually have an arts background. So one of the things that I have brought to my career, I hope, is my arts-based methods in research and using those arts-based methods to engage with children and young people and their families right across the spectrum, but particularly in complex needs and palliative care needs. So I'm taking my grandson so that he can learn about art, yes.
Good. Right. Okay, Ray McMorrow, do you like to tell us about you, 2 or 3 minutes?
My name is Ray McMorrow. I'm a mental health and learning disabilities nurse who most of my career I've spent in CAMS, and as Sir Alan and Jane were introducing themselves and reminding myself that when I was kindly made a fellow a couple of years ago, my youngest son Googled it up on the internet, of course, to find out what it was and find out who those people, and rang me up and says, "Blimey, you're in with some serious people there. They're all profs and things like that." So, and I said, "Yeah, I know. I feel a bit intimidated when I'm with this group." And I think myself almost as a portfolio, so that's very modern, career in which I've sort of traveled with the opportunities that came my way to make differences. I'm not an academic nurse by background. I have a master's, bits like that, but I trained originally in London in the East End, in the old-fashioned psychiatric hospitals like Goodmayes, worked in forensic mental health care at St Andrews in Northampton, and in Bermuda for a few years as well, where else would a young person spend their youth but in Bermuda, you know, such a fine point, where I was probably better known as a folk singer and runner than as a nurse. But, you know, I learned a lot out there because it really introduced me to issues of transcultural thinking around work and how presentations in mental health were not stable when you took them across different cultural backgrounds. But ultimately, I spent most of my career in children's mental health and in safeguarding across the Midlands, really, between Northampton, Birmingham, Derby, etc. And really why I'm here probably as a fellow, and that I would say of my career was what I did identify early on was that traumas were real. That, you know, when I started mental health, you know, there was a Freudian domination of thinking, you know, and so when we've seen what were adult patients describing sexual abuse as a kid, they were actually seen as delusions or, you know, hallucinations, etc. I mean, back then I used to think, really? You know, this is a very surprising thing to me as a young man. I thought it seemed a strange sort of delusion. It didn't really fit with anything else. And over the course of my career, really, I came to recognized that the voices of young people who are talking to me were real and authentic, and that my drive has been to give them those voices, to explore the empowerment of young people, and to allow them to tell their own stories, and to realize the importance of safe adults. And I think we may talk some more about that as we come along, but that's, I think, why I'm here tonight.
Okay, thank you. Well, we'll have some specific questions where we'll be able to expand on that. So can I go back to Jane again?
Yeah.
Right. The first question really is a broad one. How has nursing for children and young people changed in your career and experience? And try and put it in sort of a wider context of, you know, what has been happening over the time of your career.
Okay, so I thought about this question, and I thought that what I'd like to focus on is when I first started training, I don't want to sound like that was in the ark, it isn't that long ago, it's the 80s. Actually, there were still visiting hours in children and young people's nursing. And I have seen that change right through my career to families being invited into the care, much more family-centered care, to then children and young people being involved in that care, as you know, and care being around them rather than the nurses, you know, saying the care. And that's been a massive change over many years, slow but sure, if you like, Alan. And I hope in some small way that I've been part of that, you know, sort of movement. One of the things I championed right from the start, I think, as a student nurse, and then as a staff nurse, was called, and then as an educationalist and a researcher, is to hear the voices of children and young people in a way that meant, you know, something to them, meaningful to them, but was also robust, and to bring children and young people and families together to actually try to make some changes for care. And I'm really proud of that. I was one of the first nurses, along with amazing professors like Faith Gibson and Bernie Carter, to really sort of pioneer those methods and to ask difficult questions in difficult places, especially with this group of complex needs children whose numbers were growing and are still growing, and they are surviving. And these are difficult places to go, talking about preferences for your death with a child. But I like to feel I have been part of that and part of that change. I've also seen lots of changes, I think, around the increase of technology and innovation. And I think that that's a really exciting medtech, digital technology, innovation. That's a really exciting movement for us. I think what we might say to ourselves is, it's all right, we know about this technology, but actually what we don't know in the NHS is really how well to use it smartly, to bring data sets together, small and big, so that we understand and can predict public health data or disease data or information in a way that, you know, using that technology to the best. I think we've still got to learn about that and how we actually use it to make care, those care changes. So I suppose those are my two big changes I've seen. I've also seen, and I'm very proud of, the development of actually children's nurses, or nurses that care for babies, children and young people, and their specialist skills, because the specialism of children's nursing is nothing like when I started. The fact you said, was it 84 paediatricians in Newcastle? That is a very specialist skill, and it requires nurses who have got safe, responsive, highly tuned skills to care for that group. And I'm really proud of seeing that development, and really privileged to work with some amazing, bright, intelligent, reactive, excellent nurses who work in the specialist world. So I've seen that, and I would like that to continue. Those are my three things, if I'm allowed three things.
And I mean, how do you think nurses have coped with the increases in technology. I mean, I remember when I was looking after newborn babies in 1972 at the General Hospital in Newcastle. The ward sister introduced herself as, "I'm the electric sister." She had a screwdriver in her top pocket,
yes,
and she could fiddle with all these machines. You know, clearly the technology has been extremely important. I mean, how do nurses feel about all the technology? How have they adapted? Are they trained in it?
I think it depends on, actually, you've said the clue there, because the word cope depends, I know Ray thinks the same, but the word cope depends on if they've had the training and the confidence to do it. You know, I would hate to think that all too many times that nurses are left on the front line trying to sort out technology and being, you know, right there, not actually understanding. We would like to see it, or I would like to see it, that technology is smart and is robustly tested, and that those teams who are using it feel confident to use it. The nurses I work with in Nottingham and in the community settings all are very competent and are very well trained, as are the parents now. So the parents are trained in it too. But you're right, I think we do need to really look quite seriously at not just the development of technology for technology's sake, but actually how we use it, who's using it, and the skill training they have to use it. Yeah.
And do you know, just a few random thoughts around that, particularly around the increasing use of technology, particularly for the really chronically challenged children, breathing problems. Do you think that, you know, do you think we put too much pressure on parents to utilize that technology?
I don't think we put so much pressure on them because they often want to do it, but I do think we often rely on them, probably sometimes more than sometimes. It's quite good to have check-ins with them to say, you know, how are you managing? Because we shouldn't just give it to them to do, and then it becomes their role and, oh, you know, ticking it off, yes, the parents are doing it. And yeah, I'm sure you've seen those situations. I think it's our responsibility as of nurses to create a safe environment where parents can say to us, or carers can say to us, actually enough, or I don't want to do that, or I can't do that, or can you show me that? And we should be able to put that framework around that family. So it does concern me, yes, like you're suggesting, but the teams I work with are all very proactive in that training of families. But you're right, I think we are in danger of that.
But it is interesting that when we see, you know, the things that get into the press where, and it's often around home ventilation and things, there are big differences across the country in how these things are managed and where the flare-ups come. And it's interesting to look at why that might be. And one of the suggestions made is that parents actually don't know what they're getting themselves into.
Yeah.
But, you know, if they're going home with their home ventilation, you know, they don't know that that's unending. And one of the things that, you know, where some people try is that they send them home for a week or a fortnight or a month's trial of what it's like. And then that actually changes their whole attitude to, you know, that they can't, you know, they realize that they can't go on doing that.
Yeah.
We'll come back to that in a minute or two. Ray, do you want to do say something about mental health? Everybody's got mental health these days. What is mental health? Been a lot of discussion about mental health of young people, particularly over COVID-19. And have we changed the way that we are thinking about that? I know in the area that I live, the number of teenage suicides has gone up dramatically. How, you know, why should this be? What can we do about it? What are you doing about it? Not specifically you, but you know, what is the profession doing about it?
Yeah, that's That's an interesting question. In some ways, I will go back to picking a couple of things that I would see as having changed in my time as a nurse. And I think the first one to say is what we know, and this applies probably across nursing, that up until really the turn of the millennium, up until then, our perception of human development in the context of brain development and those areas, that the brain had grown to whatever size it was at the age of 2. So from baby to that, and most of it was done. That was, I think we used to say 97% of brain development had been done by then. And then it was just about how you looked after it. Give me a child until the age of 7, as the Jesuits used to say, and I'll give you the man and woman. But the reality of what we've learned since is this is not actually true. And actually, the flexibility and development of the brain and the human body is much more fluid and much more capable for many years, and certainly up to the age of 25. So that changes how you relate to the talking therapies and how you engage the talking therapies in ways that can be much more co-produced and co-constructed with the young people themselves. Strangely, it gives some credence to some of the old therapies as well. So whereas for many years, psychotherapy was seen as sort of floundering in the wind, really, talking therapies, you still have the jokes about, the sort of, I didn't realize my therapist was dead for 6 weeks because I was lying on the couch. But actually, we now know that human interface is a really critical element. So mentalizing work, which Anna Freud lead on, and I myself practice in, is all about helping very vulnerable young people to develop and change their own perception of self. As is the IAPT models are much more immediate, goal-centered, but some of these around those kids who are at risk of suicide, who would be the ones I would mostly work with, we now have models which we are developing and trying to develop the research behind these things, which actually help to, in some ways, reprogram themselves by themselves to find their own way of making sense of those things. So those things have changed enormously. The other one, which you've touched on to some degree, Sir Alan, is the expectations have changed in families. And I think my best example is sort of 20 years ago when I was in Birmingham, kids would come in and just come in and they'd be like, oh, I don't want to be in CAMS, I don't want to be in mental health service, I'm not mad, I'm just bad, I'm bad, and say, okay, you can be bad, we don't do bad. You had to reassure people that they didn't have a condition. Whereas now they're bashing down the door and saying, I've got this condition, I Googled it. I have the extraordinary experience sometimes of young people coming into me and saying, I've looked it up and I've got borderline personality disorder. And you go, oh, hold on, my advice would be don't have it if you can, so let's just put that. But actually, because people have Googled up and people are condition focused, and this is played out in the internet and it's played out in those areas. Suicide rates generally have been fairly stable for quite a long time. And they did rise in the period post 2008. And so there is some relationship between young people and poverty, which is quite worrying at this moment in time. The stories around COVID, which we're really only understanding now, are not straightforward. We do know that older teenage girls are doing badly for some reason. Eating disorders are on the up. Self-harm, depression, those things are on the up. And they seem to be really struggling. I don't know if that's caused by COVID or those things. I still think that's possibly as much to do with TikTok and Instagram as it is to do with COVID. And actually, perhaps there was more TikTok and more Instagram during COVID because people were stuck at home. Younger teenagers appear to have done better out of COVID, perhaps because they didn't have to race to be adults in this commercialized world that we live in, and this highly sexualized world that we live in at this moment in time. They're clearly managing different complexities to our generation. They're very different complexities. And we are only learning what the potential of technologies are in that context. But maybe we'll come back to that.
So, I mean, what can we as medical professionals do to try and improve things? Clearly, once people get into your system with their diagnosis that they've made, I mean, how can we stop them doing that? How can we stop them looking at the internet? How can we stop them? You can't stop them being sad, but you can stop them having mental health.
No, you can't. Yeah.
When does sadness become mental health?
Yeah, that's a very good question. People always say these days, but you know, I think that is one of the challenges is the risk that we are pathologizing normal behavior or normal experiences, anxiety, difficult things. I think we need to define better what is mental unwellness from, of course, we've all got mental health because we've all got physical health. And, you know, we'll all have twinges in physical health as we'll all have, but they're not illnesses, you know, and we'll all have minor illnesses which will affect us and even affect our mental health and vice versa. But actually, when is it difficult? But lots of our stories of mental health in the media with adults as well as with young people isn't really focusing on mental ill health, isn't really focusing on people who are really ill. So we don't get a great deal about the young people who are, unless they commit suicide, you know, or they die in an eating disorder situation. We don't hear about them. We don't hear about the growth of them in the same way. And the effects of their interface with complex society. There is a sense that perhaps schools are struggling to be a place where young people flourish. The tighter we set the boundaries around curriculum, the less space there is for young people to ebb and flow, because we're checking them out every time, you know. Whereas actually, most of us think of our growth. There'll be some bright people who probably don't, but you know, most of us can remember our education as something that ebbed and flowed. It went well, and then it didn't go well, and then it'd go well, and bits of it, and you'd flourish again. But now, if you're flourishing and then you start to fail a bit, the sense of failure is very powerful, and it's very individualized. The student or the pupil has become a commodity for the school. It's a marker for, you know. So in fact, you lose the sense of the young person as a person. Because actually what it is what's the marks we get out of those kids, you know, that's what matters. So even though teachers and educationists, you know, are human and really care about the kids, the targets that they've been driven by are not always human. You know, they're not about the human development of that person. So the challenge for us is how we get, I think, particularly an education system that is about a more holistic thought about how that young person develops. Not to reduce the educational requirements, but to actually be more holistic in how you think about how those kids actually develop.
And how do you know, parental expectations are huge in that whole sort of dynamic. And, you know, if you're saying as a professional, you know, we ebb and flow in our educational attainments, and I certainly did, and I'm sure most people do. You know, how do we actually educate parents to allow that to happen? without pushing them too much and pushing them into not eating. And
parents themselves are under deep pressure at the moment, don't they? They sort of, that actually the parents are within that system. The perception that it's a difficult place out there for young people becoming adults. So almost from babyhood, almost there's this anxiety about what's the future for that young adult. And I'm looking at Jane, there's babies in your household, and actually the anxiety about their future, I believe that anxiety is greater than I would remember it being. Jobs are highly competitive out there for young people. They're hearing the stories of houses, they're hearing the stories of war, and they're hearing the stories of catastrophe in the context of environmental matters and things like that. So it's quite easy for parents to feel we've got to get them, I think my wife's saying, oh, I'm going to say, I've had an email from a family who's saying, he's got to get into work. We've got to get him a job. He's got to work for the summer. He won't have practiced work and things like that. Can you talk to him about that? I'm saying, well, not if you want me to carry on working with him, because actually he needs to get to that place himself. But there is huge pressure on them. The pressure is very real. We've created a highly competitive culture, and the pressure on them is very high to achieve and get there. So the parents feel that. The drive for diagnosis is often driven by resource access. If I can have a diagnosis, then I can access more resources for my child. And that's completely understandable, and I completely get that. So I do understand that. So that's about us changing the system so that the resources that child need are built around a holistic view of that child, rather than actually having to give them a diagnosis, which strangely enough might cost them a job later in life. So the chap who wants to be an airline pilot in the RAF, there's an example that comes to mind, but also wants a diagnosis of autistic spectrum disorder, which probably fits for him. But if he gets it, he won't get in the RAF because they won't take him, even though the skills required to be an airline pilot match the skills of somebody who's an autistic mind.
Don't worry when you're going on your package holiday. The pilot is all right. Okay, could I just go back to Jane, particularly, and you come in as well, the question of involving young people in research, their treatment. I guess it's different. Principles will be the same, but Jane, tell us about the work that you have been doing with young people, particularly disabled young people, to try and find the best ways of managing them. And can you bring in something about transition? Because I think transition is one of the most, that is transition from childhood to adulthood, not transition in gender or anything else.
So, gosh, over the last, I think, 10, 15 years, I started using arts-based methods and co-creation techniques with children and young people. And that work started in Bristol, where I used to work there, an amazing research centre. And we tried out, championed, developed different approaches with children as young as 2, right up to young people, young adults, rising 25. All of them that I've worked with, well, the majority have had some kind of complex need in the complex needs, and some of them, as you know, were profoundly disabled or had complex syndromes. Some of them were non-verbal, some of them were in the services of palliative care. So each project I've done, I've tried to treat that almost like its own case study, because that's the way I think works best, and think of what might work best in that situation, rather than just, just getting something out of a toolbox. I've actually thought about, well, what are the aims of the study? How can I robustly do this so that it becomes meaningful. That's an overused word, but that's the word I'm thinking of now. And I've done that in different settings, community and acute trusts, hospices, during that period with fantastic teams working to elicit those views. And I've used all different types of techniques, actually, Alan. So I might use, when I say arts-based, I might use symbols, or I might use something tactile, or I have used things like role play. I don't do acting myself, just so you all know, but I would bring an expert in. It might be that I've used photographs. So I've done a number of studies in Birmingham, Bristol and Coventry where we use photographs as the sort of medium, or music, or all sorts of different types of arts-based. One thing I never have done, and this is just personal because it's very well researched, but I have never done it because I don't really believe in it, and that's draw and write. So it's a psychology technique, for those that don't know, where you draw something and you ask somebody to explain it. And that's because I suppose philosophically, I think that's quite threatening, because if I asked you to draw now, that's could be quite a challenge. So although I've used, yeah, because we're not all artists, are we? So although I've brought symbols along and fuzzy felts and creative things and made platforms and done all this stuff and technology and photographs, I've never ever used the technique of draw and write. But psychologists do use it, and they use it very well, and it's well researched. But I personally haven't used it. But all sorts of things in all sorts of capacity. One thing I always do is, when I prepare the techniques with the team I'm working with, or our teams, really think about the objectives of the study, so you don't get sidetracked, because it's so easy to get sidetracked when you're doing arts-based methods. Always practice them, like doing I call it a dress rehearsal, practice them. Think it through exactly what you're going to do. And I always try to get things so they're spick and span. There's nothing quite like a shiny packet of pencils, or opening a packet that's brand new. If you give out of date, sort of not great resources to a child, they'll soon be turned off that arts-based workshop. But if it looks like you've prepared well, you value them, you're listening to them, you give them something that looks new and means something to them, actually, that works.
Can you give me an example of a child with a problem? What was the problem? And what did you do, and what was the outcome? How did it help?
So
a very specific example.
Yeah, a very specific example was a project we did in Bristol. It was with young children under 5. It was a project called Child Talk, led by Professor Sue Ralston. And it was to speak, we had to elicit the views of children who were largely non-verbal, who had been diagnosed with some kind of speech and language need. They avoided saying the word problem, so need. Many of them were very difficult to work with. They were young as well. And so we thought of all these different techniques that we could use. And what we ended up using was a range of techniques that were interactive and visual. So they were not based on any words or anything like that. We used lots of puppetry and exciting materials that they could touch. And through that, we then gained their trust, the team I worked with in Bristol, to try to understand their world of being assessed by an adult. Now that project, the data that we collected for the National Institute of Health Research, so a national funder, changed the way that children with speech and language needs under 5 now get assessed. So we were very proud of that, because at the time they were getting assessed largely by professionals to the parents. We changed it by saying that the children actually needed to be included in that assessment more than they were. So I'm very proud of that work, because
you should be.
Thank you, because people realized actually, while working with the children, using this we ended up with a sort of toolkit of things, actually they got more out of the assessments. Yeah, so that was quite a challenge. And you can imagine going to ethics with that and discussing that project under 5, can you really do it? but we did do it over 3 years, yeah.
So how do you, if this, I mean, has this been mainstream?
Yes, not totally, but the actual Child Talk project is cited nationally and internationally. It's all been written up, papers written, and people use those techniques. The speech and language therapists use those techniques in their assessments now. Yeah.
Okay, right.
Mainstream is a bit ambitious to say, isn't it? But it is used.
You have to have ambition.
I have ambition, but it is used widely, and it's widely respected work, so that's good. Yeah.
Ray, have you any experience of working with young people themselves to develop new methods?
Yeah, I do, and I think, unlike Jane, I probably can't claim central part of it in that way. But I guess the best example, if you want a specific example, is I did quite a lot of work around the Rotherham child sexual exploitation, and we worked with the group of young people who had been exploited. And for me, as a strapping bloke, going into that room with them was very, very careful. I always remember saying, I think I learned something from David Attenborough, really, was, because I actually remember going into a room and holding my hands like this and sitting down quietly to begin with to assure them, because I could feel the sort of anxiety around who is a strange man, which is absolutely understandable. But the stuff we did with them, and it's interesting about, there's a big difference between therapy and drawing and therapy and doing that work than doing this work. I would always say help people to be good at stuff. Young people being good at stuff. So make things that they want to make that does their story. And for some of them, so that got me into the world of hip hop, so making music, making poetry, and one of the striking things about our teenage world and we talked a lot about internet and all that, is they seem to love board games. You bring out a board game to a group of teenagers and they're like, let's go. Wow. So we had them actually create board games around risk. And so they create their own risks around virtual towns on a board that you would go around and, what should you do? And, is this, and dodgy people in cars and things like that would be an all part game. And they evolved that game. They took it up to Manchester, took it up to Professor Rowland up in Manchester. They worked with, and that all went wrong to begin with in the very bit, because he was very enthusiastic and they immediately went, we're off and they're all getting back in the trade and we have to get them back in. So that's okay, didn't mean to. And then they work on it, but actually, one of them is now one of the leading voices in the country. She speaks. Last week she was on TV. She speaks. She talks to government. She challenges for young people, and it came out of that group. And actually, she does it now. There's no need for us to be involved in that, because she and some of the people from that all developed their own skills, so that they developed the next group of young people who come in, and you give them those opportunities to do that. I am proud of that.
Yeah.
And when she gets in touch, I'm very proud of that. I feel, I've done that, and I'll be honest, I've done it as a bloke. It's very important, so, that actually, because actually I think it's possibly important that there was male input into that actually cared for them, because that is part of the process is, they want to find trusting relationships, and they still want good parental experiences. And providing that is part of allowing them to create. So creating is really the crucial. And it has to be different next time.